Welcome to the deep dive. Today, we're getting into something absolutely fundamental, the human immune system. Not just its amazing defense capabilities, but what happens when it goes wrong.
Yeah, it's a fascinating area. This system protects us from, well, almost everything foreign, but sometimes it malfunctions, leading to these really debilitating diseases.
Exactly. And we're going to explore that whole spectrum today from disorders where there's just too little immune activity, like immunodeficiency.
Right, to disorders where there's too much or it's just pointed in the wrong direction. Think hypersensitivity, autoimmunity, transplant rejection. And we'll finish with a deep look at HIV/AIDS.
We've pulled together the core sources on this. Our goal today is really straightforward. Connect the underlying mechanism, the pathophysiology to
Yeah.
what you actually see in a patient, the symptoms, the clinical
hmm
picture, and reinforce that key terminology along the way so it sticks.
Let's jump right in then. Immunodeficiency disorders. Basically, the immune system isn't up to the job. How do we start breaking these down? Well, the first big split is primary versus secondary. Primary immunodeficiency disorders, or PIDDs, are the inherited ones, genetic defects. There are over 130 known now.
Wow, 1/3. Okay. And secondary.
Secondary, or acquired, means it develops later. Things like malnutrition, certain cancers, immunosuppressive drugs, or, of course, HIV can cause it.
Okay. And clinically, does it matter which part of the immune system is hit, like B cells versus T cells?
Absolutely critical. It determines everything. Let's take B-cell deficiencies first.
Yes.
Humoral immunity. B cells make antibodies, right?
Right. So if they're not working, you're vulnerable to extracellular bacteria.
Exactly. You see recurrent infections, especially with those encapsulated bacteria. Think S. pneumoniae, H. influenza. The kind of antibodies are really good at handling. Viral defense is usually okay, though, because the T cells are still working.
Makes sense. Are there common examples?
Sure. There's transient hypogammaglobulinemia of infancy. Sounds scary, but it's usually benign. Maternal IgG drops off. The infant's own system is a bit slow to ramp up IgG production.
But it catches up.
Yeah, usually resolves by age 3. But then you have something much more serious, like X-linked agammaglobulinemia, XLA.
XLA. That sounds severe. What's the specific problem there?
It's a defect in a key enzyme called Bruton tyrosine kinase, or BTK.
And BTK does what exactly?
It's absolutely essential for B cells to mature. No functional BT means B cells get stuck in the pre-B stage. You basically have no mature B cells circulating, leading to profound hypogammaglobulinemia, very low antibody levels.
So no BT, no mature B cells, no antibodies. A direct line to severe bacterial infections.
Precisely. And we should also mention the most common PIDD, which is selective IgA deficiency, SIGAD-GAD. Here, it's mostly just the IgA antibody that's low, affecting mucosal immunity.
Okay. Now, if B cell defects are bad, you mentioned T cell deficiencies are considered the most severe. Why is that?
Well, T cells are kind of the field generals of the immune response. They're crucial for dealing with fungi, protozoa, viruses, intracellular bacteria, plus they help coordinate the B cell response too.
So if T cells are down, basically the whole adaptive immune system is crippled.
Pretty much. Protection against a huge range of threats just collapses.
The classic example here is DiGeorge syndrome, right? That developmental defect on chromosome 22.
That's the one, 22q11.2 deletion. It affects embryonic development, crucially causing the thymus to be absent or severely underdeveloped hypoplastic. And the thymus is where T cells mature.
But wait, DiGeorge often presents with varying levels of T cell deficiency, doesn't it? If the thymus is the maturation site, why isn't it always a complete wipeout?
Good question. It really depends on how severely the thymus development is affected. Even a small, partially working thymus remnant can produce some T cells. So you get a spectrum from mild issues to profound T cell deficiency.
And DiGeorge isn't just about immunity, is it?
No. You often see other midline developmental issues, cardiac anomalies, renal problems, and importantly, hypoparathyroidism. That causes low calcium, hypocalcemia, which can lead to tetany, muscle spasms, sometimes very soon after birth. It can be life-threatening.
Okay, and when both T and B cells are profoundly deficient.
Then you're looking at severe combined immunodeficiency, SCID. This is really devastating.
How does SCID typically present?
Infants are lymphopenic, meaning very low lymphocyte counts. They fail to thrive, get severe, recurrent, opportunistic infections, things that wouldn't bother a healthy immune system. Sadly, it's often fatal within the first year or two without an immune system rebuild, usually via a hematopoietic stem cell transplant.
What causes SCID? Genetically.
Several mechanisms. The most common is X-linked, a defect in the common gamma chain. This protein is part of several crucial cytokine receptors needed for lymphocyte development, especially T cells.
So that one faulty protein cripples multiple signaling pathways.
Exactly. There are also autosomal recessive forms, like adenosine deaminase or ADA deficiency. Lack of ADA leads to a buildup of toxic metabolites, particularly toxic to lymphocytes, especially T cells.
Okay, that covers the adaptive immunity failures. What about the innate side? Complement and phagocytosis disorders.
Yeah. Right, innate immunity. The complement system, that biochemical cascade, it's crucial for inflammation, tagging pathogens for destruction, punching holes in them directly.
So defects there would also increase infection risk.
Definitely.
Yeah.
Especially defects in key components like C3 or the later proteins that form the membrane attack complex. You see a big jump in susceptibility to certain high-grade bacterial infections, classically Neisseria infections like meningitis or gonorrhea.
But complement failure isn't just about infection, is it? There's a link to autoimmunity, too.
Yes, a very strong link, particularly to systemic lupus erythematosus, SLE. One of complement's jobs is cleaning up immune complexes and debris from dying cells. If components like C1q or C4 are missing,
The cleanup crew is short-staffed.
sort of, the immune complexes and cellular trash hang around, deposit in tissues, and can trigger that autoimmune response leading to lupus. It's quite fascinating.
And the most dramatic complement disorder.
That would have to be hereditary angioneurotic edema, HAE. This is an emergency. It's caused by a deficiency of C1 inhibitor.
The off switch for part of the cascade.
Exactly. Without C1 inhibitor, the early part of the complement cascade and related pathways runs wild, releasing vasoactive peptides. This causes spontaneous, massive swelling deep in the tissue's angioedema.
And if that happens in the airway?
It's life-threatening laryngeal edema, airway obstruction. Requires immediate attention.
All right. Now, what about the actual eating cells? Phagocytosis disorders affecting neutrophils and macrophages.
These are the cells that engulf and destroy microbes and clear debris. You can have problems with them getting to the fight or problems with them actually killing the bugs once they eat them.
Like problems getting there. Adhesion issues.
Right. Leukocyte adhesion deficiency, LAD, is a key example. The neutrophils can't stick properly to the blood vessel walls or follow the chemical trails, the chemotaxis, to get to the infection site effectively.
And problems with killing.
The classic one there is chronic granulomatous disease, CGD. The phagocytes can engulf bacteria just fine.
But they can't digest them?
Precisely. They lack a functioning NADPH oxidase enzyme complex, sometimes called FOX oxidase. This enzyme generates reactive oxygen species, like superoxide, which are needed to kill the ingested microbes. It's like they swallow the enemy but don't have the weapons to finish the job.
What kind of infections do CGD patients get?
They're particularly susceptible to catalase-positive organisms, bacteria like Staphylococcus aureus, and also fungi like Aspergillus, because these organisms can break down the little bit of hydrogen peroxide the cell can make. We also see Chiari-Akigachi syndrome, where the granules inside the phagocytes are abnormally large and dysfunctional, messing up killing and other functions.
Okay, we've thoroughly covered the too little immunity. Let's flip to the other side. Hypersensitivity reactions, when the immune response is excessive or inappropriate and causes damage.
Right. The Gill and Coombs classification gives us 4 main types based on the mechanism involved. Type I is the one most people think of as allergy.
The immediate IG-mediated one.
Exactly. First exposure to an allergen pollen. Food, whatever sensitizes the person. Plasma cells make IgE antibodies specific to that allergen. This IgE then coats the surface of mast cells and basophils. They're like loaded mines.
And the second exposure.
The allergen comes along again, binds to the IgE on those mast cells, cross-links them, and boom, the cell degranulates, releasing a flood of preformed mediators like histamine, plus newly synthesized ones like leukotrienes.
Leading to those immediate allergy symptoms.
Yes, the primary or initial phase happens within minutes, vasodilation, leaky capillaries, smooth muscle contraction like bronchospasm. But there's also a secondary, late phase, hours later.
What happens then?
That involves recruitment of other inflammatory cells, especially the eosinophils. They release more mediators, causing more prolonged inflammation and tissue damage.
And if this type I reaction goes systemic...
That's anaphylaxis, a potentially fatal body-wide reaction. Catastrophic drop in blood pressure, widespread edema, severe airway constriction, an absolute emergency. Local reactions are things like allergic rhinitis or food allergies.
Okay. Type 2 hypersensitivity. Antibody-mediated.
Correct. Here, IgG or IgM antibodies bind directly to antigens on the surface of the host's own cells or tissues.
And what does that trigger?
Several things. It can trigger complement activation, leading to lysis or phagocytosis of the cell, like in autoimmune hemolytic anemia, where antibodies target red blood cells, or Rh incompatibility between mother and fetus.
But type 2 isn't always about cell destruction, right? You mentioned it can modulate function.
This is where it gets really interesting. The antibody binds, but instead of killing the cell, it interferes with its normal signaling, sometimes blocking it, sometimes activating it.
So the same basic mechanism, antibody binding to a cell receptor, can have opposite effects.
Exactly. Look at Graves' disease. Autoantibodies bind to the TSH receptor on thyroid cells, but they mimic TSH. They constantly stimulate the receptor, causing hyperthyroidism. The thyroid goes into overdrive.
Wow, and the opposite.
Myasthenia gravis. Here, autoantibodies bind to acetylcholine receptors at the neuromuscular junction, but they block acetylcholine from binding. So nerve signals don't get transmitted properly to the muscle, leading to muscle weakness.
That's incredible. Same mechanism, totally different outcomes, overactivation versus blockade. Okay, type 3.
Type 3 is immune complex mediated. Here, antibodies, IgG or IgM, bind to soluble antigens floating in the blood or tissues, forming antigen-antibody complexes.
And these complexes cause trouble.
If they're formed in large amounts or aren't cleared effectively by phagocytes, they can deposit in various tissues, particularly blood vessel walls, kidney glomeruli, joint linings.
And then what happens?
Once deposited, they activate complement. That recruits neutrophils, which release enzymes and reactive oxygen species, causing inflammation and tissue damage, often manifesting as vasculitis or inflammation of blood vessels. Serum sickness is a classic systemic example. Maybe after receiving foreign serum or certain drugs, you get fever, rash, joint pain about a week or two later as complexes deposit widely. The ARTHIS reaction is a localized type 3, causing tissue necrosis after repeated local exposure to an antigen.
Got it. Finally, type 4, cell-mediated.
Right. This one is different because it's driven by T cells, not antibodies, and its delayed takes 24 to 72 hours to develop because it involves activating T cells and recruiting other cells like macrophages.
What kind of reactions are type 4?
The classic example is allergic contact dermatitis, think poison ivy or nickel allergy. Sensitized T helper cells, specifically T1H subtype usually, recognize the antigen presented by skin cells, release cytokines, and recruit macrophages, which cause the inflammation and rash.
So it takes time for those cells to get activated and migrate.
Exactly. Another example is hypersensitivity pneumonitis, an inflammation in the lungs often triggered by inhaled organic dusts. It can actually involve both type 3 and type Y mechanisms.
What about latex allergy? That seems common in healthcare.
Latex is tricky because it can cause both type I and type 4 reactions. You could have an immediate, potentially life-threatening type I reaction, IgE-mediated, to the latex proteins themselves, or a delayed type 5 contact dermatitis reaction to the chemical additives used in manufacturing the latex gloves, which shows up a day or two later as a rash. Important distinction.
Okay, let's shift slightly to autoimmune diseases. This is where that fundamental line between self and non-self breaks down, right? Loss of self-tolerance.
Precisely. The immune system mistakenly identifies components of the host's own body as foreign invaders and launches an attack. We see this in diseases like SLE, rheumatoid arthritis, type 1 diabetes, Hashimoto's thyroiditis, many others.
How does the body normally prevent this? How does it maintain self-tolerance?
There are two main checkpoints. Central tolerance happens in the primary lymphoid organs, the thymus for T cells, bone marrow for B cells. Lymphocytes that strongly react to self-antigens during their development are essentially deleted or inactivated.
So the really dangerous ones get weeded out early.
Mostly. But some autoreactive cells inevitably escape. So we have peripheral tolerance mechanisms acting in the rest of the body to functionally silence or suppress these escaped cells.
So autoimmunity happens when these tolerance mechanisms fail. What causes them to fail? What are the triggers?
It's complex, and often multifactorial genetics play a role, environmental factors. But some key mechanisms are proposed. One is the release of previously hidden or sequestered antigens.
Like antigens from places the immune system doesn't normally patrol.
Exactly. Tissues like the testes or the inside of the eye are somewhat immunologically privileged. If injury or infection exposes antigens from these sites, the immune system might see them for the first time and react as if they're foreign.
Makes sense. What else?
Molecular mimicry is a big one. This is where a foreign antigen, say from a microbe, happens to look very similar structurally to a self-antigen.
So the immune system mounts a response to the microbe.
And that response, whether antibodies or T cells, then cross-reacts with a similar-looking self-antigen, causing damage. The classic example is rheumatic fever following a group A streptococcus infection. Antibodies against the strep bacteria cross-react with heart valve tissue.
That's a scary consequence of a common infection. Any other triggers?
Superantigens are another factor. Some bacterial toxins can non-specifically activate huge numbers of T cells at once, potentially overwhelming tolerance mechanisms and triggering autoimmunity.
Okay. Let's connect this to transplantation. It seems like a related problem, the immune system recognizing non-self.
Absolutely. In transplantation, the main targets are the major histocompatibility complex, MHC molecules, called human leukocyte antigens, HLA, in humans. Your HLA profile is unique, like a cellular fingerprint. The recipient's immune system recognizes the donor organ's HLA molecules as foreign antigens and attacks.
And the rejection can happen at different speeds.
Yes, we classify rejection based on timing and mechanism. Hyperacute rejection is almost immediate, within minutes or hours. It's caused by pre-existing antibodies in the recipient that recognize donor antigens, often blood group antigens or HLA. It's essentially a massive type 3 reaction in the graft's blood vessels.
So that's bad news right away. What about later rejection?
Acute rejection usually occurs days to weeks after the transplant. This is primarily a T-cell-mediated response. Recipient T cells recognize donor HLA molecules and directly attack the graft cells, or release cytokines that recruit other inflammatory cells.
And chronic rejection.
This is a slower, smoldering process that happens over months to years. It involves both T cell and antibody contributions, leading to gradual fibrosis and narrowing of the graft's blood vessels, ultimately causing the organ to fail. It's often driven by cytokines produced by T cells, stimulating smooth muscle proliferation and scarring.
Now, there's also the reverse situation, isn't there? Graft-versus-Host Disease?
All right, GVHD. This is most common after allogeneic hematopoietic stem cell transplantation, bone marrow transplant. Here, it's the donor's immune cells, present in the graft, that recognize the recipient's tissues as foreign and attack them.
So the transplanted immune system attacks the patient. What conditions are needed for that?
3 things usually. 1, the graft must contain immunocompetent T cells. 2, the recipient must express antigens, like HLA, that the donor T cells recognize as foreign. 3, the recipient must be immunocompromised enough that they can't reject the donor cells first.
Where does GVHD typically manifest?
Acute GVHD often targets the skin, causing a rash, the gastrointestinal tract, leading to diarrhea, nausea, and the liver, causing jaundice and liver enzyme elevation. It can be very serious.
Okay, this brings us to our final major topic. Acquired Immunodeficiency Syndrome, HIV/AIDS, the most significant secondary immunodeficiency worldwide.
Indeed. HIV is a retrovirus, meaning its genetic material is RNA, not DNA, and its devastating effect comes from its selective targeting of a specific immune cell, the CD4 T lymphocyte, also known as the T helper cell.
The very cell that's supposed to coordinate the immune response.
Exactly. By destroying CD4 T cells, HIV systematically dismantles the adaptive immune system, leaving the host vulnerable. Transmission is primarily through sexual contact, sharing contaminated needles, or from mother to child during pregnancy, birth, or breastfeeding.
Let's walk through how HIV actually gets into and destroys those T cells. It's a multi-step process, right?
Yes, a 7-step cycle. Really a masterpiece of viral pathology. It starts with step 1, attachment. The virus's outer envelope protein, GP120, binds specifically to the CD4 molecule on the T cell surface. It also needs to bind to a co-receptor, usually CCR5 or CXCR4.
Okay, it docks onto the cell.
Step 2, fusion and uncoating. The viral envelope fuses with the T-cell membrane, and the viral core, containing the RNA and enzymes, enters the cytoplasm.
Step 3 must involve that RNA.
Right. Step 3, DNA synthesis. This is where the retroviral magic happens. The enzyme reverse transcriptase uses the viral RNA as a template to synthesize a complementary strand of DNA, and then synthesizes the second DNA strand, creating double-stranded viral DNA.
So it converts its RNA genome into DNA. Sneaky. Step 4.
Step 4, integration. Another viral enzyme, integrase, carries the viral DNA into the T cell's nucleus and inserts it, integrates it, right into the host cell's own DNA. At this point, it's called a provirus.
So the cell's own genetic code now includes the blueprint for HIV.
Precisely. It can lie dormant there for a while. Step 5 is transcription. When the host T cell gets activated, it inadvertently starts transcribing the proviral DNA along with its own genes, creating viral messenger RNA.
Step 6, building new viruses.
Almost. First, the viral mRNA gets translated into long chains of viral proteins, a polyprotein. Step 6 is cleavage. The viral enzyme protease cuts these long chains into the individual functional proteins needed to build new viruses.
Okay, now assembly.
Step 7, assembly and release. The viral RNA genome and the newly cut proteins assemble near the cell surface, and new virus particles bud off from the T-cell membrane, often destroying the cell in the process. And these new virions go off to infect more CD4 plus T cells.
It's a relentless cycle of destruction. How does this play out over time in an infected person?
It generally follows three phases. First is the primary infection phase, soon after exposure. Often feels like a bad flu or monofever, fatigue, rash, swollen glands. Viral load is very high during this time, and the CD4 plus count takes a temporary dip but then recovers somewhat.
Then things seem to calm down.
Yes, that leads into the second phase, chronic asymptomatic or latency. The virus is still actively replicating, mostly in lymph nodes, and the immune system is fighting back, but it's a losing battle. The CD4 plus count gradually declines over years. The median time without treatment is about 10 years. The person often feels well during this phase.
Until the CD4 count drops too low.
Exactly. That marks the transition to the third phase, overt AIDS. The diagnosis of AIDS is made either when the CD4 plus T cell count falls below 200 cells per microliter or when the person develops one of the specific AIDS-defining opportunistic illnesses.
And those illnesses are the direct result of the collapsed immune system.
Right, things like pneumocystis jirovecii pneumonia, PJP, severe CMV infections, chronic candidiasis, toxoplasmosis of the brain. Also, certain cancers that are normally kept in check by the immune system, like Kaposi sarcoma and certain B-cell lymphomas.
How is it diagnosed and treated now?
Diagnosis usually starts with screening tests like EIA or ELISA, which detect antibodies to HIV. If positive, it's confirmed with a more specific test like a Western blot. PCR tests detecting the viral RNA or DNA are also crucial, especially early in infection before antibodies develop, or for monitoring treatment.
And treatment.
Treatment has been revolutionized by highly active antiretroviral therapy, HAART. This isn't a cure, but it can suppress the virus dramatically. It usually involves taking a combination of 3 or 4 drugs that target different steps in that replication cycle we discussed.
Like blocking reverse transcriptase or protease or integrase.
Exactly. Reverse transcriptase inhibitors, protease inhibitors, integrase inhibitors, and transfusion inhibitors. Hitting the virus at multiple points makes it much harder for it to replicate or develop resistance. HAART allows many people with HIV to live long, relatively healthy lives by keeping the viral load undetectable and preserving CD4 plus T cell counts.
So we've really covered the gamut today, from the immune system not doing enough, like an SCID or XLA.
So doing way too much or attacking the wrong targets, like in hypersensitivity reactions in autoimmune diseases.
And finally, the targeted destruction of the immune system's key coordinator by HIV.
It really underscores how crucial immune balance is. We saw how tiny molecular flaws, a single enzyme defect like BTEC, or a missing inhibitor like C1INH, or even the precise way a virus like HIV docks onto a cell can cascade into massive systemic problems. The system's complexity is its strength, but also clearly its vulnerability.
That complexity is just astounding. Thinking about how, say, an antibody binding can either kill a cell or hyperactivate it, depending on the context, it really makes you wonder, doesn't it? Are these different categories of dysfunction, deficiency, hypersensitivity, autoimmunity truly separate? Or are they maybe just different ways the system can wobble off that fine line of balance? Something to think about. Thank you for joining us for this deep dive. We hope connecting these mechanisms to the clinical picture helps solidify your understanding.